Yeah.
Yes, as soon as the red box appears.
Yeah.
Okay.
Hi everyone. Thank you for joining us this afternoon. Apologies for being a few minutes late starting. It takes a while to get these things set up. So welcome. So we're here to talk to you today about a consultation that we launched back in January, which is currently live until the 24th of March. We really hope you find this a useful and informative session. We're going to do our best to stick to time, but please do bear with us during this. It's quite tricky doing these large events live. Even a year into the pandemic, we're still getting used to the different ways of working that we've had to deal with. So just to introduce myself, I'm Vickie Priest. I'm the interim head of Primary Care and Community Health Services Policy at the Care Quality Commission. There's a team of us here today supporting this webinar. Just to explain a bit about how it's set up. It's only set up so we can talk and we're able to speak. You are really able to post questions and comments in the chat, and we really encourage you to do that. And we're going to talk you through the proposals in the consultation, and we're going to pause at two different points for lots of questions. And the team that you can see listed there will be there to answer all the questions for you. So please do use the chat as much as you'd like to pose questions and comments. This webinar is also being recorded and it will be available on our YouTube channel after the event. So let's get started. On to the next slide. Thank you. So today we're going to talk briefly about CQC's role and purpose. We're going to talk briefly about our strategy consultation that's currently live and is finishing very soon. But we're really going to focus on a second consultation that we launched at the end of January, which is proposing some really specific changes for how we want to move to become a more flexible and responsive regulator. We're going to pause for questions at 2 points, as you can see in that agenda. So lots of chance for you to do that. There are some quite detailed and kind of complex proposals, so really also happy to take questions and points of clarification as well when we pause for those questions. So moving on to the next slide. Thank you. So as you know, CQC was set up in 2008, and we were set up with a really clear purpose, which was to make sure that health and social care services provide people with safe, effective, compassionate and high quality care, and that we continue to encourage those services to improve. We remain really committed to that purpose, and it feels as vital as it has ever felt since 2008. But we really recognise that the world in which we regulate has changed significantly since 2008, and especially so in the last 12 months or 13 months now. And we know that in this new world, we must also transform how we work. And we really want to make some changes to the way that we regulate so we can be more relevant, and we need to be more flexible in how we are able to assess quality in times of uncertainty. And as the last year has shown us, we need to be able to be much more dynamic and flexible in how we regulate. I think in doing all of this, we know that it's not enough to look at how one service operates in isolation. So when we were set up in 2008, we were very much set up as a regulator of individual services. We know now that it's not enough to look at how services operate in isolation. It's really about how services work together that really impacts on the care that people receive. So we need to move our approach to regulating on to really reflect the fact that health and social care works as a system and not as individual providers. Thank you. So on to the next slide. So we've recently launched a consultation on our strategy for the next 3 to 5 years. I'm not going to talk too much about this today because there's lots of information out there about our strategy consultation, but just to briefly touch upon what's in that, because it's a helpful context to the other consultation that we do want to focus on today. So our future strategy in the consultation is built on 4 interlinked themes that we think we want to determine the changes that we make to how we regulate. So just to run through those briefly, we want to put people and communities at the heart of what we do. And we really want to evolve our approach so that regulation is driven by people's experiences of care and is really driven and really gets to the heart of what people expect and need from the health and social care services they access. We also want to become a smarter regulator. And what we mean by that is we want to be much more dynamic and flexible in the ways in which we regulate and assess quality. We want to be able to be much more targeted and proportionate, and also make it much easier for services to be regulated by us and make that interaction much more smooth and seamless. We also want to continue kind of a core focus on safety. So safety continues to be a key concern, as it's the poorest area of performance in our assessments across health and social care services. And we really want to focus on promoting open cultures where the voices of health and social care staff and also people who use services really drive improvement in safety. And we also want to continue to do more with what we know about the quality of care and really support the kind of drive towards improvement across services and across systems. And I think throughout each of these themes, there are two kind of core aspects of this. And one of those, which I've talked about already, is how well systems are working together. And also, I think it's really clear that the pandemic has highlighted the kind of vast inequalities in outcomes for people and how they access and how they use health and social care services. And we really want to renew our focus on reducing inequalities and play our bit in that agenda. So once the consultation is closed, we aim to publish our final strategy in the next couple of months. And the aim is that we'll implement it over the next 5 years. So that we can be really flexible and adapt to the changes that we're seeing across health and social care. Thank you. On to the next slide. Thank you. So this slide here is the reason we're here today, and we're going to get into some more detail about the proposals in this consultation. So COVID-19 obviously has made health and social care services think differently and change the way that they work, and we're really no exception. In some kind of really practical ways, in the last year we haven't been able to visit and inspect services in the way that we are used to, so we've had to quite quickly be flexible and develop and test different ways of gathering evidence, different ways of assessing quality and assessing risk in services, and the last year has kind of really tested how we've done that. I think in addition, since we introduced ratings in 2014, 2015, over those years we've built up a series of kind of quite rigid rules around how and when we can and do update ratings and assess quality. And I think we know that we need to move on from that and be able to update ratings much more flexibly and much more responsively to be able to really reflect the quality of care that people receive in a much more real-time way. And the proposals in this consultation are starting that kind of journey towards a simpler, more responsive and proportionate approach to rating and assessing quality. The consultation itself also talks about some changes to the way in which we plan to consult and engage on the changes that we make to how we regulate. So there's quite a lot to cover. I am going to pause just briefly there for some initial kind of questions. I think we're going to get into some more detail, so it might be that we cover some of the questions later, but happy to take some questions now. I'm going to hand over to, I think, Jenny, who's going to help with identifying the questions.
Thanks, Vickie. Yeah, just to say first, there are a lot of questions about people having to join the event anonymously and whether they'll get slides afterwards. So yes, we will be sending out the slides afterwards. So not to worry about that. Yeah, loads of really interesting questions coming through, especially around the inequalities and systems themes that are cross-cutting through there. Let's find a specific question to bring up. There's also a couple of questions about visits and how this will impact on, I guess, operationally, and and whether experts by experience are going to be involved in the new ways of working. I don't know if one of the colleagues wants to address that.
So I suppose my initial response is I think we're going to talk about the site visits a bit more in the next session. So I wonder if we kind of cover that in a bit more detail. That might answer some of the questions. In response to the question about experts by experience, there's nothing in here that suggests a change to using experts by experience in inspections. I don't know if Dave, you wanted to add anything from your perspective on that.
Hi, thanks. No, that's right. We'll continue to develop and use that. It's a really important part of our approach in social care, but actually in all our sectors. So absolutely, that's not going away. We'll continue to develop.
Thanks, Dave.
Thanks, Dave. I think most of the questions that we're getting through are about the specific bits that we're about to cover in the next section of the presentation. So perhaps we crack on and then take some more questions in the later session.
Yep, more than happy to, thank you. So on to the next slide, thank you. So the next few slides set out some of the proposals in the consultation. Some of them are quite detailed, so bear with us as we try to explain these in a kind of simple and clear way. So the kind of main proposals in the consultation, which apply to all of the sectors that we regulate, relate to changes to how we assess quality and rate services, using a wider range of approaches, not just on-site inspections, and a move away from a fixed schedule of inspections. So taking the first point, we want to move away from comprehensive on-site inspections being the main or the only way that we can update ratings of health and social care services. Inspections and site visits remain a really important aspect of what we do, and a really key way in which we can gather evidence about the quality of care that people receive, and they're more or less important in different types of services, and they will continue to be a really important part of what we do. But I think historically we've always viewed ratings as synonymous with inspection, and actually we want to move away from that approach and be able to make better use of the evidence we have that indicates the quality of care has improved or deteriorated, and to be able to update ratings more frequently and more flexibly without always having to rely on an intense comprehensive on-site inspection. In addition, we currently have an approach where our inspection schedule is a fixed schedule based on the previous rating that we've given to a service, and we propose to move away from this approach and introduce a much more flexible and less rigid approach that allows us to kind of update ratings more frequently and inspect more frequently depending on the risk, and allow us to be much more targeted and proportionate in how often we inspect or assess services. There's a slight shift in how we describe this, so we want to stop describing frequency of assessment in terms of inspection, and actually instead talk about how often we will review quality and update ratings. And the purpose of all of these changes that we're setting out here is to enable us to be much more dynamic and flexible in how we are able to reflect changes in quality in the ratings that we present on our website and the judgments about the quality of care. There's a lot more work to do, I think, behind all of this that will help us to develop exactly what this will mean across the sectors that we regulate. But this is the start of the process, and we want to really work closely with providers of health and social care, with the public and with stakeholders to really develop what this actually means in practice and how this will work. So on to the next slide. Thank you. So moving on to a couple of more specific proposals that relate to our assessments of GP practices and NHS trusts. So when we first introduced our ratings for GP practices, we introduced ratings for the 5 key questions, so safe, effective caring, responsive and well led. And we also introduced ratings for 6 population groups, which included older people, it included long-term conditions. we have continuously evaluated this approach to try and work out if it's actually achieving the purpose, which is to identify whether practices are providing good care to different population groups. Based on all of the feedback that we've had from GP practices, from our own inspection teams and from the public, we believe that this has become, it's made the process of rating GP practices too complex and too confusing. We often weren't seeing any variation in the different ratings that we had for the different population groups, and it was adding a kind of unnecessary complexity to our approach to rating. So in this consultation, we're proposing that we move away from rating GP practices on these 6 population groups, and that we instead just rate GP practices on the 5 key questions, so safe, effective, caring, responsive and well-led. I think what we're not saying here is that we will stop considering how practices provide proactive and personalised care to their populations. This will still form a fundamental part of our assessments. We just won't construct ratings in that kind of overly complicated way. So the second proposal on this slide and in the consultation is that we are proposing to remove aggregation for NHS trust level ratings and replacing it with a single trust level rating. So we'll continue to inspect and rate the core services that we currently inspect and rate for NHS trusts, and we'll continue to inspect and rate the well-led at the trust level. The bit that we're proposing to remove is the approach to aggregating up from the service level and location level ratings for safe, effective, caring and responsive. Again, the feedback that we've had from doing this over the years is that it's an overly complicated approach to ratings. It wasn't really adding value to what the public want to know about the quality of services provided by a trust, and it often concealed variation in service level kind of quality of care, and it also wasn't flexible enough, so we also couldn't update the ratings enough to really reflect what was happening within a trust. So on to the next slide. So the final part of the consultation talks about a change in how we want to consult and engage on changes to how we regulate in the future. So historically, we have launched kind of 12-week big consultations on our end-to-end approach of regulating and inspecting health and social care services. What this has meant is that actually it's quite a slow process for us to change how we do things, and it went far beyond what we are required to consult on under the Health and Social Care Act. So what we want to do is move towards a much more kind of ongoing process whereby we are able to constantly, through a range of different methods and ways, get feedback and views about how we're regulating it and how we're assessing quality across health and social care. In all of this, we're really clear that where we do need to consult, we will consult, but we'll do that in a much more targeted and responsive way, making it much easier for providers and the public and stakeholders to feed into what we do and how we work. And we hope that's the intention is it's an easier and more open and transparent way of consulting and engaging. And what it means is that we will always be able to have really up-to-date information on our website about how we regulate, that providers and the public can go to understand what we're doing and how we're regulating. So that is all I was going to say there. There's now more of a chance for some more questions. There's quite a lot of detail and kind of quite complex stuff in there, so really happy to answer any questions that people have.
Thanks, Vickie. So we've had a lot of questions about monitoring and data and what sort of sources we're going to be looking at when we talk about how we're going to look at practices or services remotely. So moving away from scheduled inspections and using remote data, will we be reviewing that on a continual basis, and what are the sorts of data that we'll be reviewing as opposed to just on-site inspections?
Thanks, Jenny. I think that's a really big question from my perspective, and I'd be interested in what others, so Dave and Matt, might have to contribute from the trust and the adult social care side of things. But I suppose from my view, I think we have to recognise that there's different available data and evidence across the sectors that we regulate, so that the answer might be quite different depending on which service type or sector we're talking about. And in terms of how often we're able to use data that has changed, again, it depends on what that data is and how often it's changing. And I think that the kind of overall point in all of this, I think, is that we need to do some kind of more work to develop some of the detail behind the proposals in here. Anything to add, Dave or Matt, to that?
Yeah, I mean, I think what you said there applies for social care as well, Vickie. I suppose for our sector, there's something about how do we turn the vast amount of information that's out there, for instance, from local authority, contract monitoring and quality monitoring activities from Health Watch and from other sources, how do we turn that information into data? At the moment, we have good relationships with our commissioning counterparts and with Health Watch, but we don't have a kind of a common data set that we all draw on. So I think there's still quite a bit of work to do, not just for CQC, but for health and social care partners in general, to really make the most of the information that's out there and turn that into usable data. And the second point, I think, for social care in particular, but maybe for other sectors too, is with the continual digitisation of care, actually the benefits of that in terms of being able to extract information from providers to be able to share information direct from their care management systems looks like a potentially helpful development for everybody. At the moment, we've got 30% of social care providers using those systems, and I know there's lots of work going on to encourage and support providers to develop those systems in the future.
Thanks, Dave.
Yeah, I mean, just to add to that, I suppose at a high level, it's about how do we find the right balance between information that is easily available through national data sets or information that we receive directly from stakeholders or service users about the quality of care of individual services versus information that we collect in some way from the provider themselves. And in terms of information from providers, it's that question of how do we find the right balance of doing that in a way that is the right level of frequency and the right level of kind of comprehensiveness to enable us to make a judgment at the right point in time for that service without it becoming too burdensome. So we certainly need to get better at collecting data and using it, but also there's some decisions to be made about both in terms of the information we collect on a monitoring basis, and then that might form any specific formal assessment. So as Vickie says, it's a balance, and we need to work through the detail, but it will look different in different sectors depending on the available data that we have through national data sets in particular.
Thank you, Matt.
Thanks, all. So I guess a question that's linked to that, there have been a few questions as well about inspections. Obviously, on-site inspections will still happen in response to risk, but one of the questions we've got through is about how will providers be able to demonstrate outstanding care based on written qualitative evidence without a physical inspection?
Yeah, I think that's a really good and really important question, and I think our challenge is to develop an approach which allows us to identify where services have improved and where they're outstanding, whether that's by inspection or by reviewing evidence kind of remotely or kind of off-site. Yeah, I think that's a really good question. I don't know if anyone else has anything to add to that, but
I mean, I think the answer to that may depend partly, it may be different for different key questions even, or different parts of our assessment framework will be easier to assess through data alone or through off-site inspection activity, or assessment activity, sorry, relative to other parts of the assessment framework. So I don't know, something like the effective key question, if you're familiar with the detail of our assessment framework, things about the outcomes of of care in a sort of qualitative sense. A lot of that sort of stuff, or aspects of the responsive care question and waiting times, are somewhat easier to assess remotely through data or through other forms of evidence that we can gather remotely. Whereas things like the caring key question or aspects of well-led might be harder to assess without inspection. So it'll be a question of where does inspection fit within that, and there may be, potentially some key questions might be able to move up more easily to outstanding, even based on movements in data or other information we have alone. But we're going to have to work through that level of detail. It'll vary again depending on individual sectors and individual types of services as the data is available, and as we evolve the assessment approach, that will sort of iterate over time.
Yeah, I think from my perspective, I suppose from my perspective as well, there's something about, just because we're moving away from inspections or physical site visits being the only way that we assess quality, actually what we talk about when we talk about an outstanding service, the evidence isn't changing potentially, it's just how we gather the evidence. So it's almost like a change of method rather than a fundamental change to what we mean by outstanding or how we might assess it. So it's almost kind of reverse. So it's thinking about what's the evidence that I might need to decide if a service is outstanding, and then how might I best gather that? Is that a site visit or an inspection, or is that remotely? So it's just kind of a shift in assumption that inspection is the first thing that we will always do to gather any evidence.
Thanks both. Another question linked to I guess data gathering is about, we've had several questions about the PIR and how this will look going forward, whether it will be held as I guess a live document, and any changes we're expecting to make to that.
Is that about a particular service? Just because we have a slightly different approach to PIRs across different sectors. So the overall answer is that that's something that we need to work through and think through. But Jenny, if it's about a particular sector, we might be able to give a bit more of a view. If it's not, that's fine.
I can't see a particular sector specified, so if people want to drop in the chat whether it is, that would be helpful. We've also had a couple of questions about domiciliary care and home care, about the types of visits that they usually get and what they might look like going forward. So Dave, would you mind talking about the pilot?
Sure. Yeah. So we've just concluded a pilot to inspect and assess domiciliary care agencies, but without actually visiting. And there's, I guess, for some time we've queried the notion of how wise and how necessary a visit to that office actually is to understand the quality of that service. There's no actual care being delivered there, so that's why we wanted to test this out. And we worked with the UK HCA, the trade body, on this, and it's actually gone really well. So we did a number of inspections without crossing that threshold. We gathered evidence remotely. We're still able to engage with staff. We increased our engagement with people that use services by 70% as part of this approach. And I think, playing back to some of the points earlier about how can we make an assessment without actually visiting, and to the point that it will really depend on the model of care. At least one of the services we inspected using this pilot methodology was basically outstanding through this approach. So we definitely want to continue to, certainly within domiciliary care, to roll out this approach. But actually, to Matt's point, this really is about which bit of evidence is best suited by which method. And it may well be that in residential care, for instance, in social care, that lots of what we currently assume we have to gather on inspection can be gathered remotely, not at the time of inspection, and we just reserve that inspection for the really important key parts in terms of observing care and meeting people and understanding what it's like to live in that setting. Hope that helps.
Thanks, Dave. Yeah, I think that does help with the questions we were getting through. We're also getting a lot of questions about, obviously ratings is a big theme in this consultation, and a lot of people are asking about if people want to be re-inspected and re-rated, if we're not going by a frequency table, what will trigger inspections, and how can they be re-rated?
Yeah, it's a really good question, and I think, I mean, the purpose of all of this is to allow us to update ratings more frequently and more flexibly to really reflect where there have been changes in the quality of care, whether that's getting better or not. I think we need to work through the detail of what that means, and I think it's just that shift from talking about a set inspection frequency based on a previous rating to just recognising that actually we'll be reviewing what we know about a service on a more regular basis, and we'll be able to update ratings following that process more easily, which doesn't give a kind of black and white answer, but our aim is to be able to update ratings more frequently, and all of these proposals are helping to take us there. But again, I think the last year has been tricky for us in being able to re-rate services, because we haven't been able to inspect in the way that we wanted to for really good, valid reasons. Services are busy, and we shouldn't be sending our inspectors into services unless it's completely necessary. So we know this is an issue, and we know it's one we have to address fairly soon. But absolutely, the intention is that we can update ratings more frequently, which we hope will be beneficial for providers and the public.
Thanks, Vickie. We've also had a few questions about how our transitional approach is going to feed into this new, into the new strategy. Perhaps we could get a view of that from the different sectors.
And of course.
Yeah, happy to. So, did someone speak then? Sorry, I thought someone was starting. Yes. So I think the transitional approach, where we developed the emergency support framework, and then the transitional monitoring approach, all of that has been really important learning for us, and it's a really important step that we've taken to enable us to get better at assessing evidence and assessing quality without always inspecting, and to support us to be kind of more targeted and more proportionate in how we work. I think Dave's just talked about how we've tested out some different ways of working in domiciliary care, and that's a really important thing that we've done this year, that we've learned and developed. But I think it's probably fair to say we'll continue to transition. This will be a period of where we continue to transition and learn and develop kind of how we do things over the coming months and years, in line with the proposals set out in the strategy. I don't know if anyone has anything else, Matt or Dave or Ro, anything to add across the sectors?
Just, I suppose, just reflecting on one of the earlier webinars like this, what we heard from lots of providers was how much they appreciated the through the ESF calls and also the transitional approach, just the kind of increased contact with the inspector and how supportive they've found that. And I think that's something we want to bottle and take forward. I think we're at different places in different sectors on that, but I would certainly not take the fact that we're talking about maybe using inspection less often or only when we need to mean there'll be a reduced contact or even reduced visits. Actually, it's just that we're going to be using visits and contact in different ways. And a really big part of our strategy is actually about accelerating improvement, and what we're hearing is relationships and a good dialogue with inspectors is a really important part of that. So I think that's one part of the transitional approach that we'd want to carry on growing.
Yeah, I would echo that, Dave, and I think just to add a little bit about some of the testing that we've been doing in primary care as well with our GPs, and the learning that we're sort of getting through from that, which is similar to what Dave talked about in terms of the domiciliary care. As we've talked about and reflected, the pandemic definitely limited our ability to undertake site visits, and we had to think about how we could do things differently during this period. And as a result, we've piloted a focused and targeted inspection approach for GPs in response to risk, and that's involved us collecting more of our evidence remotely and using technology to support things like virtual video interviews and remote reviews of clinical records. So it might mean that in the future we can learn from that and collect evidence and information in different ways, and that might look and feel a bit different than it has in the past, but lots of really great learning coming out of that, and the evaluation's ongoing at the moment.
Thank you.
Thanks all. We've had a lot of questions as well about our CLOEs and the assessment frameworks that we currently use for inspections and ratings. Can we talk about the process for whether they'll be changing and how we would develop that?
Yeah, that's a question for Dave, I think.
I'm happy to have a go. Yes. So I think it's fair to say they do need a change. We do like to keep those frameworks up to date anyway, even if we weren't looking at kind of the start of a new strategy. We're right at the start of that process, though, and actually we really need to understand how people, what people say in response to our consultation, and more than that, we will be working with people on this, you know, that join this call, and with all of our stakeholders really to develop and evolve our assessment framework. I guess a few pointers in terms of what the strategy is pointing to and what we've heard. It perhaps doesn't make sense to talk about wanting to have a clearer role across pathways of care and systems, and as lots of people will know, a potential role in assessing local authorities, and to then go on and develop lots of different frameworks. We currently have two, and arguably we might want to see if we can just have one, so that we don't have to have one set of questions and evidence for health and one for social care. That said, while it would be helpful to articulate quality in a way that works for all the providers that we regulate, and actually for systems and potentially for local authority commissioners as well, digging down into the detail, clearly you can't expect the same sort of evidence and the same sort of ways into that evidence, such as through the key lines of inquiry, to be the same for a one-bedded care home and for a large multi-site NHS trust. So I think it's going to be about how do we make sure we have continuity from our ratings approach now? We're not going to be throwing all that away. How do we evolve rather than completely start again? How do we come to a more consistent view of quality across the different sectors? But then how do we then differentiate and reflect the very different realities that providers face in terms of their sector, their scale, their model of care, and so on? So lots more to do on this over the coming months, that's for sure.
I think those are challenges that we've always had to address, and you know, we started off at different times having different assessment frameworks. We had the high-level key lines of inquiry and ratings characteristics, but we've gradually brought those together into a simplified approach between health and healthcare providers in particular, and social care. But then, you know, within different services at the moment, we have quite a lot of additional detail below that high-level assessment framework in terms of the inspection approach for specific service types, which go into a lot of additional detail about the additional questions that are relevant to that sector, the relevant standards, all of that. There's a lot in that. There's a huge amount of detail in that, which is helpful in the sense of being quite specific of what we look at in individual sectors, but it does make the approach very complex and introduces inconsistencies, I suppose you could say, different approaches between different service types. So again, it's that question about how do we find the right balance of making the assessment framework and the assessment approach that draws on the framework the right level of consistency across the different sectors, and the right level of simplicity so that it's easy to understand, and we can make assessments in a sort of as simple way as possible, while reflecting appropriately the different contexts, as you say, Dave, of different sectors. So, you know, with all of the things we're talking about here, this is the start of a conversation. We've set out a high-level set of ambitions in the strategy, and we're starting with the consultation on some of the flexible changes to get into the details of what that would look like in individual in specific pieces of policy that might change around ratings or you know, the frequencies of assessments and all of that. But you know, we're going to need to keep talking about the detail. This is about starting to get into the more specific detail about what will change, but there's clearly, you know, there's more detail that we'll have to work through with all of these things, whether it's the assessment framework or the frequencies or any of it.
Thanks, Matt and Dave. Jenny, do we have any questions on the specific proposals about NHS trust ratings and GP practice ratings? Just thinking we haven't touched upon those yet in the questions, and they're quite detailed and probably quite complicated things to explain. So happy to take any questions on those if there are any.
Yes, sorry, I just wanted to loop back quickly to the PIR
yeah.
question that we had before, because a
Yeah.
lot of people have been commenting specifically about the large NHS trust level PIR. I don't know if, Matt, if you could touch on any changes you're expecting to that.
Sorry, what's the specific question?
It's the future of PIRs, I think, and how do PIRs fit into what we're talking about here. I think it's a general question. I think, Jenny, wasn't it?
Yeah.
Yeah.
So I don't know the detail of that. Again, as with all of this, as we look at the assessment framework and the approach to gathering information, including from providers, we need to look at all of that in the round. I think where we're trying to get to with the provider, with the PIR, is to get away from these big sort of complex Excel spreadsheets that we have to send out in advance of the inspections, and ask people to complete and move to a much more flexible way of doing that. But that obviously requires getting the technology right, and linking in with all of the wider changes that we're talking about in terms of the assessment framework and how we use evidence to come up with judgments, how we report all of that. So I don't have a specific time frame for exactly when the PIR itself will change and what way it will change. We're still going to need, certainly for the time being, to gather information from providers ahead of inspections, but I know we're really looking at doing that in as different a way as possible, as quickly as possible, and to make it more proportionate to the specifics of what we're going to look at, while making sure we gather enough information in advance of the inspection to help us make decisions on what we look at on site. So I'm sorry that that's not a sort of as specific as you might be looking for, but as with all of these things, there's a bit of detail to work through. But we really are, we're very aware that the PIR is a burdensome thing, especially for big inspections of NHS trusts where there's a lot of detail in it. We're really trying to move quite quickly on changing that.
Thanks, Matt. We've also had a couple of questions about the single rating at trust level, and about, because I think we've been talking about inspecting services as well, so perhaps we could just go through the process of how a single trust level rating would be reached in this new format.
So I think the basis for the single trust rating will be the approach that we've developed and been using over the last few years within NHS Trust for the trust level well-led inspection, which is the concept, I suppose, of that single assessment at the trust level is to make it clearer that have a clearer link between the assessment activity that happens at that level of the overall trust and the rating that's issued at the overall trust. At the moment, the trust level rating and the overall quality rating is a mixture of assessment activity that happens at the trust level through the NHS Trust well-led inspection and aggregated ratings up from earlier service level inspections that have been added up for the SAFE and the other ratings. So in terms of how that will work for the future, I think the idea would be to continue having that overall inspection in a similar way to what we do at the moment for the well-led inspection. I think the frequency of and the relationship of the frequency between the assessments that we do at service level and the well-led inspections will need working through, because I think that the assessment approach for well-led inspections and the type of information you need to use to make an overall judgment of a big organisation is different to the information that you use to make assessments of service level individual inspections. My guess would would make more sense to have less frequent or slightly less frequent updates to the well-led inspection to allow time for services to improve and to acknowledge the different type of assessment activity that's involved. But we're really keen to keep doing, to do all of these things at a frequency that makes the most sense, and that where the assessment activity is targeted at the right level for the audience and to reflect the quality of the service at that level. I think the other bit I'd say on that is building on the experience of over the pandemic and how we've been working over the last year. It's again that question that we're really looking at seriously of what information we can use to make assessments off-site remotely, doing interviews remotely, focus groups potentially looking at evidence off-site So I think especially with well-led inspections, and that overall organisational assessment, there's a lot we can do off-site, and we're really keen to keep building on that. So that will help us. The more we can do that sort of thing, it'll enable us to make those assessments more happen more quickly. Actually, one other thing to say on that. So one of the things we'll have to work through is when we come up with that single overall assessment, as we do at the moment, we'll need to take account of, in coming up with the overall judgment for the organisation, we need to take account of the quality and the ratings in all of the different services beneath that. So the way it works with the well-led inspection at the moment is that we, at trust level, we take account of the ratings and the evidence that we found in individual services within an organisation for the well-led key question at service level. But so that's considered as part of coming up with the judgment for the overall well-led rating for the trust. So that will need to work in a similar sort of way for that overall assessment of the organisation. We'll need to take account of the performance of the organisation at service level and the quality of the organisation in terms of its safety and its access and all of that. But without what we're trying to get away from is this very kind of rigid and sort of mathematical adding up of ratings from different chunks of service level activity that are often quite hard to compare in a really sort of clear and transparent way, especially for very complex organisations. So we'll still be taking account of the quality of the organisation across the board, but in a sort of in a more simplified way is the objective.
Thanks, Matt.
Thanks, Matt. We've had a few questions as well about, I guess, transparency. So at the moment, we have all our CLOEs and assessment frameworks on our website, and I think there's a little bit concern about whether people will continue to be able to see how to meet our regulatory questions, I guess. So could we just talk a little bit about how we'll continue to do that?
I'm happy to make a start on that. Yeah, that is a commitment that we would not ever look to move away from. And I think we probably can do more. And we'd be really interested in continuous conversation in terms of how we can be more clear and potentially more concise in how we set out our expectations. So yeah, part of that assessment framework is about how do we helpfully set this out in how we apply that assessment framework as well as part of any revised methodology. How do we better describe how our judgments are arrived at? Is there a way of doing that better than we currently do now? Can we help providers before any kind of assessment to actually understand how they are doing in certain areas, and so that we have a kind of a shared understanding of what the priorities might be when an assessment takes place, and what needs to be kind of concentrated on, and how to address any shortfalls. So yeah, absolute transparency I think is key, and I do feel like we can do more on that, and I'm keen that we do.
And I think even just taking a step back, we're required to publish information about how we assess services under the Health and Social Care Act. So, you know, Dave's kind of set out that we really want to be transparent in this, but actually we're also required to.
Yes, that's true.
Being updated.
Thanks, Jenny. Any more questions, Jenny, that you can see? If not, we can move on to the final part and wrap it up.
Yeah, there are definitely a lot of questions. But yeah, should we move on to the wrap up, and I'll keep scanning for.
Yep. Okay. That sounds good. Thanks, Jenny. Thanks for moderating the questions. I'm sure there are lots of really good questions that we haven't covered and just haven't got time in the hour that we have. But we do really want to hear more about what you think about the proposals that you've heard. You've got until the 23rd of March. Apologies for saying the 24th of March earlier. It's the 23rd of March when this consultation closes. And there's a link there to the survey, which is the quickest and easiest way to respond to this consultation. And there are other ways to respond, as you can see there, if you don't want to use the form. And we really do welcome as many kind of comments and feedback on what you've heard as possible. Thank you. On to the next slide. So this slide just sets out some more ways that you can stay up to date with what we're doing and the changes that we're making. I won't run through those because you can see them all there and you can access them after this session. So I think that just leaves me to say thank you to everyone for joining us. We really hope that you found it a useful and interesting and informative session. We really appreciate the time that you've taken out of your busy day jobs to come and listen to this. We think it's a really exciting opportunity to kind of move forward with our approach to regulating. And I think, as we've kind of touched upon in a few of the responses to the questions, this is the start of the conversation. There'll be lots more chance for kind of discussion. There's a lot more detail to be worked through as we start to develop more of the detail over the coming months. And we really look forward to working with you on all of that. So thank you from me, and thank you from the rest of the team.
Thanks, Vickie. So just to reconfirm, we'll be circulating the slides afterwards, and the session will be up on our YouTube channel for anyone that wasn't able to make it. I think one of the last things to talk about is just, obviously this is our strategy for the next 5 years, which is quite long implementation time. Perhaps we could just touch quickly on what inspection is going to look like in the meantime for everyone.
Yeah, so at the, I mean, let's chip in, but at the moment we are continuing to inspect where we find risk across all of the sectors. There are slight differences in that across the sectors and what that means. And I think we're continuing to be quite targeted and focused in the inspection activity that we're doing. I think this position will continue to evolve over the next few months. So I think the main thing to say is kind of keep an eye out on our website for kind of more information about how that's going to evolve over time. I'm not sure if we have any specific things to add from adult social care and trusts on that.
No, not for me.
Okay. Great then, thanks everyone.